Right. So, so unlike other regular intensive care patients, I know there are a lot of adult intensivists here, a few pediatric intensivists. Blood components are needed a lot when a patient is on ECMO. And the first thing that you have to do if you're planning to put a patient on ECMO is to alert your cardiac surgeon, perfusionist, and as well as the blood bank. And so we are now going to the next 20 minutes, we're going to discuss on the why, the what, and the when of blood component therapy on ECMO. So as we are all talking about, anti-10A, heparin, etc., the aim of our aim when we put patients on ECMO till the lungs and the heart recover is to avoid bleeding in the patient and clotting in the circuit. And this is a very precarious balance because you have a foreign circuit which will cause shear stress. There is loss of platelet consumption, low fibrinogen. There is the pump shear stress. And of course, bleeding can occur because of your anticoagulation. And remember, these are the sickest of sick patients. So major bleeding occurs in 25 to 60%, which is a lot. More in VA than VV ECMOs, especially if it is a post-cardiotomy and if it's a central cannulation, because then there's more bleeding from the chest. And of course, longer the ECMO runs. So what are the sites of bleed? One is the ECMO cannulae. Then you can have hemothorax or, Dr. Shiv also mentioned around the pericardium and causing tamponade, ENT bleeds, lines, surgical site, GI bleed, hemoptysis, etc. And, a lot of minor bleeds have not been reported. So whatever data we get from the ELSO is the major bleed. What is major bleed? A hemoglobin decrease of 2 grams, with new hemodynamic instability or overt bleeding or anything that requires surgical exploration comes under major bleed. So bleeding, 70% according to this study in pediatrics, intracranial hemorrhage 16% and associate with higher mortality. And another reason for low hemoglobin and reason for your multiple transfusion is laboratory blood sampling, especially in pediatrics. So bleeding and RBC transfusion occur frequently. Yet another study in adults. An amount of RBC transfusion is associated with in-hospital mortality after controlling for confounding variables. So this is very worrying. So before we transfuse any blood product to our ECMO patients, we should, stop, pause, and think whether it really is warranted because it is responsible for mortality. So what are the triggers? Why do we transfuse all these blood products? One, to prevent prophylactic, you're targeting numbers. Dr. Shiv also mentioned some numbers, or to treat bleeding, therapeutic, as part of massive transfusion protocol. So when you replace your PRBCs, you also give your platelets, cryoprecipitate, plasma, etc. Before any cannulation or procedures, you want higher numbers. Now, RBC transfusions, very often it is not because of the bleed. You want to augment oxygen delivery, at least that is the aim. And when there is shock, hypoxemia, because you want to target a higher HB, you give PRBC. Of course, if there's bleeding, you'll need to give PRBC. Now, Dr. Shiv mentioned circuit priming. So circuit priming in less than 15 kilos, we prime with PRBC because otherwise there's a lot of dilution of your hemoglobin. Hemolysis, the more higher pump speed, there is much more hemolysis, especially when you put the CRRT circuit also in pediatrics because of so many connections. So when there's hemolysis, your HP drops, and then you're forced to give RBC transfusions, which also could increase the hemolysis, but then we start chasing numbers. So this was a study which actually, just had a depiction of what transfusions and how much, what is given most. So platelets are mostly transfused, and then of course your plasma, and then followed by cryoprecipitate. So why do ECMO patients bleed? This is very important. So all of you here, you have to understand, this will be demonstrated to you in the workshop. See, the pump pressures, pre-pump pressures are negative, and they can become very negative. Dr. Dipanjan was telling about, if the cannulae are not properly placed or they are very small, then especially in pediatrics, your drainage flow won't be much. You can have very negative pressures here pre-pump. And remember, post-pump pressures are very positive. So you have such significant pressure differences. This causes shear stress, turbulent flow, and that also contributes to hemolysis. And if you're increasing your pump flow, there will be much more hemolysis because of this pressure difference, more so when you don't have very good drainage. So ECMO itself causes coagulopathy because of the inflammation. It is a non-endothelialized surface. You have activation of coagulation factors. You have platelet adhesion, activation, von Willebrand deficiency, which is acquired, and consumption of clotting factors. Now, we all know there is a primary hemostasis, and you need the von Willebrand factor, platelets, and fibrinogen to form a fibrin clot. And then after that, your secondary hemostasis, where you need your coagulation factors. Now, both these are deranged on ECMO patients. Why? Because you have an acquired von Willebrand syndrome where there is loss of this large von Willebrand multimers because of the cleavage as the blood passes through the ECMO circuit. And therefore, this acquired von Willebrand syndrome, that deficiency can cause bleed. Another problem is you're acquired this Bernard-Solier, where even your GP1 alpha, whatever receptor also is, there is shedding. And therefore, this reduces your platelet adhesion to your collagen. So just, illustrating this with an example, this was a 2-year-old girl, ECMO, cannulation, and there was bleed, mucosal bleeds, but all the tests were normal. So one has to suspect, if you have bleeds, but all your tests are normal and your ACT is not high, then acquired von Willebrand deficiency should be suspected because of shear-induced reduction of the high, molecular weight multimers. So bleeding with normal APTT, fibrinogen, platelet counts, consider this deficiency. Even factor 13 deficiency, which is, consumed, there is deficiency of this coagulation factor as well, but then the test could all be normal. So how do you treat it? Reduce the pump speed. Don't target high numbers. You don't need very high blood pressures. You don't need very high saturations. We don't have von Willebrand factor concentrate, so desmopressin can be tried or tranexamic acid. Now, thrombocytopenia. Why do we get thrombocytopenia on ECMO patients? Of course, sepsis, underlying illness can contribute, and there is an inflammatory and coagulative cascade. But ECMO itself can cause thrombocytopenia because there's addition, aggregation, there's defective aggregation of the platelets, there's platelet activation, there's dilutional thrombocytopenia if you have primed it with crystalloids or just RBCs, PRBC, platelet consumption on the foreign tubings and oxygenator. There is something called thrombocytolysis, accelerated platelet destruction, especially with high pump flows. And platelets are consumed in clots if there is ineffective anticoagulation. And as your oxygenator with prolonged ECMO. And of course, heparin-induced thrombocytopenia, where you'll have low platelets, but you won't bleed. In fact, there is higher risk of thrombosis. So this is another terminology on ECMO. It's called the Roman effect. Basically, there is absorption of all your coagulation factors and activation of your coagulation pathway. So if there is fibrinogen deficiency, your APTT is prolonged. With factor 13 deficiency, your APTT will be normal. Of course, your other coagulation factors, when they're deficient, your APTT will also be prolonged. And of course, DIC, where you can also bleed and clot. So this can also contribute to your coagulopathy. So this is, I'm a pediatric intensivist, so I'm just going to be illustrating it with, pediatric cases. So this was a patient. Remember, neonates and infants are very different from adults. This is a neonate for meconium aspiration on very high heparin. This is 45 units per kg per hour, but the ACT is not very prolonged, though the APTT is much more in the higher range. Platelets are normal. So despite high heparin, the ACT is low, APTT is high. Remember, in neonates, there's still the coagulation factors do not reach, take a few years to reach the adult level. So APTT is generally prolonged because of, coagulation factor deficiency. It is not due to the ECMO or the illness, but they do have a slightly more prolonged APTT as compared to adults, and which is not due to the heparin. And of course, hemodilution, more so in children, can cause coagulation factor deficiency, which can prolong your APTT. Also, children, infants, newborns will require much more, a higher heparin for the same effect for the same for the ACT target or the APTT target because their antithrombin levels are low. So that is something that you have to factor in, that they will require much more heparin. So don't be alarmed if you're requiring higher heparin to achieve a ACT target in small infants. And this is called the developmental hemostasis, where they have low levels of all your coagulation factors, which explains the prolonged APTT, and low levels of antithrombin, which will explain your requirement of a higher heparin in this age group. So transfusion, I was telling about, mortality and transfusion. So all these studies have shown that each additional RBC transfusion of 10 ml per kilo per day was associated with a 9% increase in mortality. Mortality was higher in those receiving a large RBC transfusion volume. Now, you could argue that that maybe these were more sicker patients, but even after, excluding these confounding variables, they found a direct relationship to RBC transfusions. Even platelets were independently associated with 2% increase in mortality and similar other studies. So what are the complications of transfusion? Why should we think twice before giving all these blood products? They can cause volume overload. Platelets and FFP can cause Trali transfusion and worsen your hypoxemia. And there is something called immune modulatory effects, which they are immune suppressive. And of course, you get more sensitized. So the more platelets you give, you could have more antibodies and you'll have refractoriness. Infection, especially platelets. Remember, platelets are stored in room temperature, so there's the higher risk of infection. And storage lesions. Stored RBCs have a lower concentration of 2,3-DPG and ATP. They are more prone to, increased stiffness, decreased deformability, and that itself can result in thrombosis. So our aim is to improve your oxygen delivering capacity, etc. But if you have lower 2,3-DPG, and if you're causing more inflammation, we could actually be causing more harm by giving blood products. So based on all this, what are the ELSO transfusion goals? If the patient is bleeding, you aim for a higher number. So platelets more than 1 lakh, INR less than 1.5, fibrinogen more than 150. With platelets, FFP or cryo. And this is the volume that you would give. Now, with regards to hemoglobin, 7 to 9 is what the current ELSO guidelines 2020 states. And this is for non-bleeding. A 50,000 platelet is fine. INR of 3 non-bleeding is okay. And a fibrinogen of 100 also. So first, let's talk about RBC transfusions. Now, hemoglobin, we've always been chasing hemoglobin, saying that it's a surrogate marker for oxygen delivery. But does delivery equate to, consumption? Just because the hemoglobin is only 10, by giving and increasing the hemoglobin to 12, are we going to improve our oxygen, carrying capacity, especially when you're causing more RBC deformability? So this is the guideline, and this is from 2022 Annals of Blood. One size does not fit all. So if the SATs are high, above 88 or 92, even a hemoglobin of more than 7 is fine. If the SATs are less than 85, then you target a hemoglobin of 9. And this is the TRAIN ECMO survey on RBC transfusion. One should be guided by your hemoglobin saturations, your lactates, signs of hypoperfusion, and SCVO2 in VECMO. So if these numbers are all good, then you don't have to give RBC transfusion just to chase a hemoglobin number. So this is another recommendation for children. There's insufficient evidence to recommend a specific RBC transfusion target. Use a restrictive RBC and platelet transfusion policy. In massive bleeding, you can give a higher RBC 1:1, 6:1:1 ratio to avoid further dilution of coagulation factors, and blood prime for small pediatric patients less than 15 kilos. In heart-lung transplant patients, a restrictive transfusion strategy to minimize the antigenic burden and the risk of antibody formation. That's another thing to be kept in mind. So this is a very important study called the PROTECT-MO, transfusion practice in patients for VV-ECMO. This was a prospective multi-center observational study from 41 adult ECMO centers in Europe, North America, Asia, and Australia. And what did they find? That during VV-ECMO, there was no universally accepted threshold for PRBC, but lower mortality only with a hemoglobin concentration of less than 7. So you can, so this is the European Society of Intensive Care Medicine that ECMO, one can still have good results with a restrictive hemoglobin target, especially even with ARDS, during weaning, even with sepsis or septic shock patients. And acute coronary syndromes, you would target a liberal hemoglobin. So when I mean liberal, it's still not above 12. It's around 9 to 10 grams per deciliter. What about FFP? This is the Canadian studies. These are the taxi cabs. They suggest against the routine use of FFP just to normalize a PT-INR in non-bleeding patients, especially on VV ECMO. So only use FFP transfusion if there is massive hemorrhage. And the ELSO guidelines say target INR 1.5 in bleeding and less than 3 in non-bleeding patients. And this is your increment. 10 ml per kilo of FFP will raise it by 30%, your coagulation factors, and fibrinogen by 40. Remember, if when there is bleeding, there's short half-life of coagulation factors, especially factor 7. So you may have to repeat FFP every 6 hours if the patient is bleeding. Another indication for FFP on ECMO patients, as I said, is to the poor man's antithrombin. Heparin binds with antithrombin to inhibit anti-10A. So this is your anti-10A. Now, antithrombin levels can be low in infants or due to sepsis or due to prolonged usage of heparin and gets consumed. So then you have to replenish it with fresh frozen plasma, which is a solution to heparin resistance during ECMO. Now, what about cryoprecipitate? So cryoprecipitate is very rich in fibrinogen. And when you are, and fibrinogen can be consumed, there can be dysfibrinogenemia on ECMO. So when you, please do, apart from your INR and APTT, please do check your fibrinogen. If your fibrinogen is low, then you give cryoprecipitate. And this is the target, 100 in non-bleeding and 150 in bleeding patients or before any surgical intervention. How much would you give? 1 unit per 10 kilo. And this is the increase. With cryo, you have a much more higher increment of fibrinogen compared to if you just give FFP. Platelet transfusion. So platelets, single donor apheresis is much better because the increment from one single donor apheresis is much higher compared to giving random donor. Random donor is also a lot of volume, plus you are exposing to many donors and therefore there's risk of more antibody, your alloimmunization, etc., and more platelet refractoriness, which can develop. Also, this was a Canadian consensus study which stated that don't keep a transfusion threshold of 50. Higher threshold only if the patient is undergoing some decannulation, high-risk procedures, or, there is a high risk of bleeding. Otherwise, 50,000 is good enough because it has been, platelet transfusion has been associated with mortality. And why? Because of systemic inflammatory response to platelets, which comes from multiple donors, as well as the biochemical changes occurring in stored platelets. So stored PRBC, stored platelets, all can, are immune suppressive. So another reason for bleed, and I think the other speakers have alluded to, this was a boy, VV ECMO, adenovirus, all the platelets, coagulation factors were normal at initiation, patient hypertensive. Very often on VV ECMO, we encounter hypertension. After the, pre-ECMO, they could have been hypotensive due to RV dysfunction, but after VV ECMO, they become hypertensive. And this was a patient you've already anticoagulated, and the pupils are unequal, and the CT is here, there is bleed. The PCO2 pre-ECMO was 116. So what are the possible reasons for the intracranial hemorrhage in this patient whose platelets, coagulation factors were normal at initiation? So this is very, very important. And I think all the speakers have also emphasized, be mindful of the CO2 drop. Now, remember, CO2 is very, very diffusible. So even if you go up a little on the sweep gas, it can drop very precipitously. So the first 3 hours, your delta PCO2, that means your change in CO2 should not be more than 25, because that is associated with the more mortality and CNS events. And in pediatric patients receiving ECMO, the delta CO2 for the first 24 hours, it should not be more than 30%, because then you have more, CNS catastrophic events. So this is very, very important because you can have intracerebral bleed. And remember, they are hypertensive. You've just anticoagulated, and this drop in CO2 can cause CNS problems. Remember, CNS bleed, very high mortality. It can occur anytime. It can be due to your ECMO-related process because of your change in PCO2, your change in PaO2 also. Suddenly, there's all your, reactive oxidants, radicals. disruption of the blood-brain barrier. I've already mentioned to you about platelet dysfunction, acquired von Willebrand syndrome, your hypofibrinolysis, which can occur at ECMO. And of course, the disease-related process, your shock liver, platelet dysfunction due to your renal failure, antibiotics. So you have patient-related as well as ECMO-related problems that can contribute to bleed, and CNS bleed can be the end of the story. Pulmonary bleed, another site, nebulized tranexamic acid. This is something that we do. We instill into the ET tube, and that is very effective. Also, you can give directly, if you don't want to give recombinant factor 7 because the circuit will clot, you can directly instill it into your into the lungs. And in fact, it's supposed to directly interact with your tissue factors to stop bleeding. It's much more effective than IV. Procedures on ECMO, think before you act, because that can cause, lot of bleed. So this was a tension pneumothorax, and then we converted into a hemothorax. So remember, unless there is, tension, do not, introduce any catheter, ICDs, no rectal drugs procedures. ET, please tell your nurses, the ET suction depth should be only up to tip of ET tubes, otherwise you will cause pulmonary hemorrhage. This has been mentioned. If there is bleeding, we don't routinely do it to a TEG, but if there is bleeding, this is invaluable. Your viscoelastic test, your ROTEM, and your TEG thromboelastogram, because it actually tells you whether you have to give FFP or whether to give platelets, or you have to give cryoprecipitate or give tranexamic acid because of hyperfibrinolysis. So strategies to reduce transfusions. So we all know transfusions can increase mortality. They can cause TRALI, more problems. So keep a lower transfusion trigger. If all your end organ perfusion, everything is good, 7 to 9 is good for hemoglobin target. You do not have to target very high APTT or ACT, because then there's risk of bleeding, and then you'll need, again, blood products. If there is bleeding, you can even run with high flows and no anticoagulation till you sort out the bleed, or even when you're doing your procedures. Now, leukodepleted products will prevent platelet refractoriness and alloimmunization. Try to get the patient off ECMO, so fluid overload, etc. Shorten the duration so that there's no bleeding. Daily sampling, especially in children, limit the amount of tests that you're doing. Strict transfusion protocol, think twice before administering any blood product. And auto transfusion, I do not know if adults do it. We do not do it, but that some centers do it during decannulation, etc. So these are the other strategies to stop bleed, stop anticoagulation of this bleed, increase ECMO flows during that time, local hemostasis. So wounds, cannulae, use your gel foam, tranexamic acid, even locally, is helpful. If there is GI bleed, you can give octreotide, replete your coagulation factors. Remember, factor 13 deficiency, which is also very common, has been reported in ECMO, can have normal APTT. And that's why your TEG is very useful rather than your APTT when there is bleeding. Transfuse platelets, hyperfibrinolysis, tranexamic acid can be given locally, nebulized, or IV. If there's fibrinogen problem, cryo. And of course, think of acquired von Willebrand syndrome, reduce your pump speed because that can cause problems. So this is the mantra for blood products and therapy on ECMO, less is more. And this is a very awaiting this trial of, tighter transfusion of red cells and ECMO from Boston. And I'm sure this the last word, this is the current evidence, the last word. So a few years before, we were talking about targeting hemoglobin of 12 to 14, and now it has become 7 to 9. So things are changing. And I'm sure we'll have one day, a day when we will not even be using anticoagulation on our ECMO patients. Thank you. Happy to.